Well, as she said, my name is Evie Harness. Right now I am working as the manager of clinical operations for NovaCare. We do contract work in geriatric settings, primarily nursing homes around, actually nationwide, but my territory actually goes all the way from Bandera, San Marcos, all the way down to Hondo. And I manage the OT, PT, and the speech practices out there, supervising them. I do also have background, though, in rehab. I worked at RIOSA for 5 years. I've worked at the VA hospital up in New York, and I've also worked in psych substance abuse. So I've had a variety of different settings that I've had the opportunity to work in. When Carolyn called, she wanted me to do a little presentation on OT and really how we fit into working with patients who have some sort of an endocrine disorder. And we do, in the variety of different settings that we work in, have the opportunity to work with patients who have those types of disorders. Some of the endocrine disorders are a little more subtle, so we end up treating not the disorder as more of a primary diagnosis, but really some of the characteristics of the symptoms will factor in when we're actually working on our treatment plan, and we'll be talking about that. I'm going to be covering, there is an outline back here. I'm not sure that everybody had the opportunity to grab one. We'll be talking just briefly on a couple of those more subtle endocrine disorders. We'll spend the majority of the time on diabetes because that's one, because of the long-term nature of it, and as they get deeper and deeper into that diabetes, the symptomology obviously gets much more severe. That tends to be one that we end up taking a much larger role with. So we'll spend a little bit more time with that, talking about things like how OTs work with the diabetic foot, the amputations that sometimes occur from the different problems that are a part of the diabetes. And pardon these are not Kinkos. I did it color-coded those, so y'all hopefully keep everybody awake. One of the different, the endocrine disorders that we occasionally will again have as more of a factor that we'll end up having to work with is hypothyroidism. Some of the different symptoms that will happen, and you may have already talked about some of these, are the dry skin, the poor skin turgor, the hair loss, the cold intolerance, fatigue, anorexia, constipation, muscle weakness, and memory dysfunction. I starred the fatigue, the muscle weakness, and the memory dysfunction simply because those tend to be the ones, those will be the symptoms that when we go in to assess the patient, that will be factoring in that the fatigue, which would cause them to perhaps have more difficulty performing their ADLs or their functional mobility. The memory dysfunction, they may have a harder time learning the cueing systems or remembering perhaps any types of sequences that we're trying to teach them. We will have to use those and be aware of these, so it's very helpful to us when the physicians actually do the history on the patient to let us be aware and know what we're working with. I'm not going to go deep into depth with these because as we go into the diabetes, we'll be talking about very similar types of issues, but just know that the hypothyroidism can actually factor in when we're working with a patient. Another one of those more secondary type disorders would be growth hormone menopause. There is a natural decrease as the patient ages in this particular hormone, and what happens is it sort of plays a part in that frailty syndrome. As you get into the elderly population, what happens is that you see the patients that appear very frail, they're very diminutive, they just seem like they fall apart when you blow on them. The effects is with that hormone, with that loss, there's an increase in the adipose mass or the fatty tissue. There's a decrease in that muscle and the bone mass. So again, it's very similar somewhat to the hypothyroidism, but again, that will play a part in what we have to address when we're actually working with the patient. We have to be aware that, again, probably there would be some fatigue. When they have the decreased muscle, it's much harder for them to perform or at the same rate that some of the activities that we might be asking them to do. All right. And then we get into the big one, which is diabetes. And we sometimes call this the invisible disability. With the diabetes, especially when they're in the earlier stages, sometimes people don't recognize, especially if people don't talk about it, that they actually have the diabetes. In fact, as you'll notice as we go down, some people are even unaware that they have it themselves. So it's not an obvious, it's not a spinal cord injury, it's not an amputation in the initial stages, but the symptoms, that fatigue, the numbness and the tingling that may be very bothersome for the person, people don't understand why the person is all of a sudden having problems doing maybe certain tasks. So it can be very frustrating for the individual when they used to be maybe very independent, now they're having trouble, but people don't believe, they think they're faking it or something like that. So they end up having to deal with that as part of their treatment program. Some of the facts, and again, you may have already heard these, so bear with me. About 18% of the people between the ages of 65 and 75 have diabetes, and they've averaged that out to be maybe about 10 million Americans. 90% are non-insulin dependent. 50% of the people or the population that have it may not even be aware that they have it. Amputations occur more often with the diabetics, and we'll be talking about that a little bit more. And it's most often as they progress into the diabetes. It's usually after about the age of 65 when the symptoms are really starting to get into the more severe stages. And a diabetic who has had one amputation is certainly at a higher risk to have another one later on. And we'll see that oftentimes in the rehab settings, that the person is already on their second one just because that peripheral vascular disease is continuing on its course, and they end up losing maybe their other leg as well. As we work, well, I almost got it on there. As we work with patients in the various settings, the OTs could notice some of the following problems with relation to that diabetes. Motorically, there's that weakness, there's the loss of weight, there's the decreased endurance and physical tolerance, and again, those will factor in quite a bit when we're trying to work up a treatment plan for them. They may not have as much of an easy time trying to work through all their ADLs. They may have to take rest breaks between the dressing and maybe the grooming and hygiene, or maybe that functional mobility is going to be much more difficult for them. They sometimes suffer a loss of reflexes or reactions, so their reaction time may be slow, or they have muscle aches and pains caused by the diabetes. Incontinence is also something that occasionally happens with the diabetes, and diabetes can, just according to one of the resources, be a real common source of the more transient type of incontinence. It can cause more really severe psychological problems, especially for a person who has never had problems with this before. There's the embarrassment, they have anxiety, they feel that loss of control. They tend to not go out as much because they're afraid they're going to have an accident, so their leisure and their social activities get curtailed quite a bit. And then ultimately, if you've got somebody maybe who's more bedridden, they can have the skin rashes and the skin breakdown that will occur with that. So this would also be another area, and this is a lot in the nursing homes that I work with. We see this more often. I don't see this quite as often in the rehab settings, but we do see this quite a bit in the nursing home, and we'll talk a little bit about it. We do have programs that we work with the nursing, usually in the nursing home. We try to get a schedule of their patterns. You know, how often is it that they have the problem? When do they go? If they go after they've had a meal, if we get them to the bathroom within a certain amount of time, do they have less incidents? So we really try to figure out a schedule, what their usual pattern or their problem areas are. Then we try to fine-tune our program to meet that need. So if they're having maybe functional problems actually getting to the bathroom, we'll work with that. We work on the functional mobility, the transfer training to help get them on and off the commode. We may have to modify somewhat if they can't get all the way to their bathroom. Perhaps we might bring in a bedside commode so they have a much easier time getting to it more quickly. We might have to work with clothing management. Perhaps they're having some difficulty with their fingers. Maybe the peripheral neuropathy has also affected their hands, so now the fasteners on their clothes are giving them trouble, so they're struggling with those and they end up going. So we may have to do some modifications with their clothing. And it's real important that we work with nursing, because as therapists, we're only there 8 hours a day. So it's real important that the nurses are aware of what program it is that we've worked up with the person, and then they sort of take it where we leave off. They work with the patients using the same either cueing systems or the same types of techniques, and then hopefully there'll be that carryover where they have less incidence of the incontinence. Probably one of the biggest things that happens as the person progresses through that disorder with the diabetes is the impaired circulation. And this is probably one of the areas that we tend to see the most patients with. The things that happen as this disease or this disorder progresses. The impaired circulation may result in myocardial or cerebral infarction and result in the amputation of the leg, and we'll be talking more about amputation in just a minute. Diabetes accounts for approximately 30% of all peripheral arterial disease. Diabetic arteriosclerosis presents with a slightly different picture. Actually, more of the arterial vessels in the diabetes are involved in this, so it may even call in the smaller, the medium, and the capillaries, which is why they have such significant loss of circulation in their legs, which often results in that, the amputation. They're more likely to present with skin infections. They have a slower rate of healing, so that's something that we really have to take into account when we're working with them. They get a higher incidence of skin ulcers, and we'll again be talking about this more in a little bit. And if they actually get that neuropathy where they end up with a sensory loss on top of the circulatory loss, then they are very much highly at risk, because they don't even know that they've injured themselves sometimes, and that can really cause a problem later on. All right. The first one that we're going to talk about with regard to that impaired circulation is the insensate foot. There are a lot of diabetic, I don't know if the physical therapist that was here talked a little bit about this, but this is one of the areas that we oftentimes will work with the people actually in whatever setting we're in, but we also do sort of community awareness types of in-services for people that have diabetes, simply because this can be such a humongous problem with the diabetics. In the U.S. overall, the cost of the treatment of the diabetic foot lesions, the gangrene, the amputations is over $200 million every single year. And what the scary thing about that number is that doesn't even take into account any kind of rehab that's given to them. This is strictly the treatment process initially. And it also doesn't take into account any type of, if they're younger patients, the lost days from work. So that's a huge problem. Diabetics are less able to resist infection, which is why a small cut can really actually get worse and worse and worse, and then end up in a lesion and then an ulcer and possibly an amputation later on. Ulceration of the foot is commonly the result of a combination of factors. That can be the neuropathic changes, the infection, and then the vascular compromise. The people with diabetes, unfortunately, have a lot of factors working against them, which makes them so susceptible to this. Just to sort of give you an idea, and I wish I had an actual picture to show you. This is sort of an idea of what the diabetic foot would look like. And again, this is as they've really progressed a little bit farther into that process. This would not be when you first get diagnosed with diabetes. This is not what your foot looks like. But they have a peripheral neurologic loss. They can have atrophic skin. They get deformed nails. Their toes can claw up because of some of the intrinsic weakness that they get in their foot. There's a thinning of the plantar fat pads on the bottom of the feet, so they look very atrophied. And then there can possibly be foot deformity and joint destruction. So it can really not be a pretty picture. And in therapy, what we generally see are 3 different types. There'll be the insensate foot, the foot that's got the sensory problems, but no ulceration at this point. So this would probably be the early stages. Then 2 would be the foot that's had the sensory problems, but now they actually have an ulceration. And then you can have the foot that has the problem, but it's now healing. And there's different treatments that we'll do for each one of those different groups. Obviously, the first one, if they don't have an ulcer, you don't want them to develop one. So what we'll work with the patient, and again, we do this a lot out in the community, just to promote that awareness of what people need to do to prevent themselves from ending up in, say, a rehab hospital later on with a more serious problem, is we teach them daily foot care. That can include making sure that they use lotions to keep the skin supple, where it doesn't get dry, where they can end up with cracks that'll end up getting worse and worse. We teach them to inspect their skin. It's very important that they look every day at their feet, because where you and I will walk and maybe clip your toe on a chair or a table leg or something and you see stars, but you at least knew you hit it. Sometimes their sensory loss is so impaired that they won't even know that they've clipped it, that they've cut it, that they've done anything. So obviously an ulceration can progress and get worse and worse and worse, and then we end up possibly with foot loss later on down the road. We also look at, teach them to be aware of any areas of pressure, because they may not feel it, but if they're wearing tight shoes, this can be especially for women who like to wear high heels, things like that, where you get that pressure on your foot, they're going to be much less aware that they've developed a pressure point or an area where there's going to be some shearing. So that's why we teach them to be taking off their shoes very regularly, to be looking if there's any reddened areas, because again, they're not going to know that just from walking around. Sometimes I think that'd be nice not to know when your feet are killing you, but anyway, type 2, that's when you've actually got the ulceration. So this is an area where actually PT will really jump in and be very active. At this point, they probably need antibiotics, which nursing and the physicians would provide. There may be some wound debridement and care that's needed to help clear up that ulceration and get some granulation going in there. We want to make sure that the limb is elevated and reduce any type of edema so they don't have a problem. And then again, it's very important to make sure they don't have any shearing forces to continue to aggravate the situation with the ulcer. All right, and remember the third area, this is where they've had the ulcer, but it's healing or it's already healed. So this is very similar really to the first one. Again, you know that they're susceptible to developing the ulcer at this point. You want to make sure that it doesn't progress any farther or that they develop a new one. So in this one, sometimes what we'll be working with is actually looking at their shoe and seeing if we need to do some sort of a modification in the shoe to make sure that they don't have that pressure on their foot. We usually try to get them to wear a shoe that's got a boxier toe. It's a little bit wider where their toes aren't all cramped together. And we usually try to get a softer top on the shoe. So again, if they've got a little bit of that clawing going on where the foot is actually, the toes are raised up, they're not going to have that pressure over the top surface of their toes. Sometimes they can find those shoes out in the community. Sometimes they actually have to go to somebody that will special make them for them. There are shear reducing liners that can be inserted into the shoes to help reduce that force. And again, that close monitoring of the skin. You don't want an ulcer to develop and get worse. Just note that one of the things that diabetes can cause is a zinc deficiency, and that zinc is very important in wound healing. So that's one thing that we try to work with the nutrition department or dietary to have them check levels and see if that's maybe something that is factoring in. If for some reason maybe a wound that they have or an ulcer is taking a very, very long time. Diabetics tend to heal slow anyway, but you certainly don't need something that you could easily help them with, cause more of a problem. Additional treatment for that diabetic foot would be keeping the body warm. You know, you want to increase that vasodilation. That's one of the things that we hear from the diabetics all the time, is that their feet feel cold, their extremities feel cold, and you want to keep the body warm. So that can be as easy as putting on a warmer pair of socks and just telling them not to run around barefoot as much. You want to avoid exposure to the cold. Again, that could be, you know, as simple as wearing shoes or socks or something like that, and not getting that extreme change in temperature. We want to protect their foot from trauma. So this is where we might actually go into their home and look at the way their house is set up. If it, you know, is it cluttered? Do they have things sitting out that maybe they would catch their foot on? Are there things they could trip over? Are there ways that we could perhaps modify the way their environment is to help it be a little bit safer for them? We pretty much ask them not to walk around barefoot out in the grass. There's just too many things that could possibly, you know, cause some sort of an injury to their foot, which for you and I, you know, we'd say ouch, and it would heal pretty quickly. For the diabetic, it can get worse and worse. We teach them to use the lanolin ointment to prevent the drying that we already talked about. We insist that, you know, any type of fungal infections, or if they get any types of ingrown toenails, that they address those very quickly. And I starred that because we don't do that. They are at such high risk to develop problems that usually they get referred to a podiatrist for that. And if that pain in their feet is bad enough to warrant that they actually go to bed and have bed rest, what we try to do in therapy is to really prevent some of those deconditioning types of things, or those secondary problems that could happen when the person's got that extended bed rest. And that could be something as simple as teaching them some exercises to keep their range of motion up. They need to get as much circulation as they can get down to that extremity. Obviously, if you're lying in bed and you're not moving around, that circulation is probably not going to be real good. So we'll teach them some range of motion exercises. We do some positioning with them. If it's a person that's very elderly that may be in bed a lot anyway, it's real important for that positioning to happen, just because you do have bony prominences. Again, you know, they probably have had weight loss. Their bones are going to be more prominent under the skin anyway. So they have to, we in nursing and anybody working with that person have to be aware that you don't want there to be an area of pressure where an ulcer could develop, like a bed sore or decubiti. And those are usually places like, you know, your ankle bone, sometimes your heel. Those are the most often seen areas that we get that ulceration in. And then again, you want to control edema. You don't want to keep it elevated too long, again, because you lose the circulation down to the area. So you can have too much of a good thing. But just to reduce the swelling if there is swelling. We also try not to use the pressure garments that you'll see, those TED hose, and that's for a couple of reasons. Sometimes they are so tight that they actually cause more of a circulation problem, and they're also, if anybody's ever tried to put them on, we work with them all the time, but you talk about a shearing force, trying to get those on, so we really try to avoid using those as a method to, with the people that are bedridden. Okay, as they progress farther and farther with the diabetes, amputation, unfortunately, can be a reality with a lot of the diabetics. And this is an area where OT and PT actually play a much larger role, because the significance, the severity of these problems impact these people so incredibly. We usually end up working with them quite a bit just to help them work through some of those daily skills that were so much easier for them before. Amputation is very commonly caused by that peripheral vascular disease caused by diabetes. It's really one of the most common reasons that there's an amputation. There's an estimation that 1 American in every 300 to 400 has had an amputation, and obviously the lower extremity amputations are much more common than, say, an upper extremity amputation. If you actually do studies, usually around the age of 55, you'll see a real sharp incline in the incidence of an amputation. So it's sort of rare for it to happen unless it's more of a trauma injury for the younger patients. When we get an individual who has had an amputation, the therapist will go in, will complete an assessment, and what we're looking at is we want to see where their abilities are. Do they have an impairment of functional ability? Do they have a problem performing their self-care skills? Do they have a balance problem, now that their center of gravity is somewhat altered? So some of the intervention that OT would be involved in would be preserving that soft tissue integrity. What we want to do is make sure that we're preventing any types of contractures, so we do a lot of positioning with these people. Initially, they might be in bed more, and they are much at risk for developing both hip contractures, and then if it's maybe a below knee amputation, they can also get the flexor contractures in their knee. So we really work quite a bit making sure that they're positioned correctly to make sure that that doesn't happen, because if at some point they can be fitted for a prosthesis, they'll have a much longer time recovering and learning to use that if they've got a contracture. We also want to make sure that we prevent any decupidi from developing, and again, this is really more when they're in the bed part of that healing disease, the healing process. We work with edema reduction. Obviously, with any type of an amputation, there's going to be some swelling. So we want to make sure that we don't get any of those secondary complications, the pain, the contractures, the soft tissue adhesions, things like that. So again, elevation is usually one of the easier ways. We also do something called wrapping, and there are a couple different methods that we can use. You can use an ACE wrap, and there's a special technique where the pressure's a little bit there's a little bit higher pressure on the distal end of the stump, and then it gets a little bit less. You relieve that pressure as you're going up. The advantage to the ACE wrap is that you can have a little bit more control over what that stump is going to look like, for later hopefully fitting them with a prosthesis. The disadvantage is it's a somewhat complicated type of a wrapping process. So if you have somebody who's just very confused, they often can't do that themselves, or if maybe they've got some of the neuropathies in their fingers and they just really can't control it or fine motor problems, again, that would be something very difficult. So the other alternative is something called a stump shrinker, and that's just a sort of a pressurized sock that they put on that's really custom fitted for them. And we do that and incorporate that into their ADL program. That has to become as second nature for them as putting on their pants, as putting on their shirt. So we really incorporate it into their ADLs. We want to increase their physical endurance and their muscle strength. That's going to be very important for them. So we really target specific muscle groups, and in their case, we really work a lot with the scapular depressors, their elbow extensors, and their wrist extensors, and that's primarily because those are the muscles that they're going to use now more than ever to be pushing up, either to do a transfer into a wheelchair maybe if they're a double amputee, actually if they're also a single and they're having to maybe rely on a wheelchair now for some transportation in those early stages, for scooting in their bed. So those are all the muscles that we really want to target, make sure that they are able to do that functional mobility activity easily. We want to make sure that we condition the cardiovascular system, and we do that through graded activities. We start them out and then work with them gradually to increase their endurance to perform their activities. We have to be a little cautious with that because the patients with the peripheral vascular disease, because of the diabetes, we really have to monitor them because they do have that fatigue factor, and also we'll talk about it again a little bit farther along, but it also, the exercises, they get more mobile, their use of the insulin may actually decrease, so there may be some adjustment levels that have to happen with their insulin as we get them started on the exercise. Okay. We also try to increase their activity tolerance, as that is often affected by the amputation. So we try to work both in the standing tolerance and the sitting tolerance. It's amazing when you think that they have an amputation of their leg that they would have a problem sitting, but they often do if there was any deconditioning involved after the actual surgery. We also try to improve their postural control. They have a lot of difficulty initially if they are placed in a normal wheelchair that you'll probably see in a nursing homes in particular are less than wonderful. But in a rehab setting, even once a lot of patients have been in that wheelchair, they tend to get more of a sling seat, and that can be very detrimental to somebody who's had an amputation, because what happens is they sink into the seat, their leg will go up or the residual limb, and they'll end up getting that flexion contracture, because, which we've been trying so hard to prevent. So we really try to put a solid seat insert where that will keep them from sinking down into the seat. We often also add onto that solid seat insert, if it's say a below or above knee amputation, there's also a little extension coming out where their leg is actually on that. And that will keep them from developing some of those contractures. We have to modify the wheelchairs often, especially for those who have had a double amputation situation. Their center of gravity is shifted back so far that their chair can actually tip over. We had a gentleman that had received his second above knee amputation, and we worked with him. We put some anti-tipping devices on his chair, and those are just really little extensions on the back of the chair that have some wheels. So if the chair does happen to tip back when they're trying to do something, that can even be reaching upwards, the whole chair can tip. He was very good in the clinic. He went home, forgot to put the tipping devices back on. They'd taken them off when they put him in the chair, and all it took was him going from his kitchen, which had linoleum, into his living room, which had carpeting. Just that little bump was enough to tip his chair over. Unfortunately, he was all right, but it certainly threw his wife for a loop when he fell like that. So it's real important. And what happens with the chairs, it's a special chair where the axis of the wheel is actually moved back slightly, so that's what the center of the gravity in the chair actually can be offset. And then we also work with them on dynamic and both sitting and standing balance. They need to learn to figure out where their center of gravity is now, so when they're reaching up, when they're reaching down to perhaps pick something up off the floor, that they know how to work with their body and work with their postural control to be able to do those safely. So that sometimes takes a lot of mat work. And then we also work with pain management. You've probably heard of people complaining about phantom limbs where they have actually had the amputation but they can feel their toes. That's a problem that they end up having to deal with. We also have to do this because if they get fitted for a prosthesis, you can imagine if you've had an amputation, just the sensitivity and when you put that prosthesis on, they're trying to put weight through it, it can actually be a very painful situation for them, and you'll see a lot of facial grimacing, and they don't tolerate the prosthesis for very long. So we use vibration. We oftentimes will let them do it themselves. We teach them the techniques and let them do it, because the more often they do it, the better. And that way they build up a little bit more tolerance for that. With ADLs, again, they may need to sort of relearn that dressing process, and a lot of that has to do with their center of gravity. Used to be maybe they could, pull on their pair of pants, and now they're going to be shifted backwards and fall over in the bed. So we have to do a lot of work with them. What surface can they be on? Can they do it from the bed? Do they actually have to be on a hard surface to be able to do it? Bed mobility, they need to learn to scoot back and forth safely without tumping over. Wheelchair mobility, if they are going to be in a wheelchair, they need to know how to take off the parts, to swing footrests if they've got those, to work their brakes. So they need to be very familiar with those in case they're going to end up going home with one. Community mobility is also very important. When you're in a rehab facility, you've got a pretty sterile environment. They've got the nice wide hallways, they've got the nice flat halls with the, no uneven surfaces. So it's real important to get them used to the fact that if they are actually going to be wheelchair bound for a good part of their time, they need to be able to go up maybe over curves, to be able to go over a rougher surface, either gravel or cobblestones or whatever you'd find out in the community. So we actually take them, some of the rehab hospitals, I know we had a sort of a wheelchair course that we take people through at RIOSA, but we often will try to take them into stores, into some of the situations where they can see what a difficult time they're going to actually have to deal with, and let them work through and process and problem solve, so they'll figure out what they need to do. Transfer training, again, is a big part of what we do. They need to be able to get from one surface to another, from a low to a high, from a high to a low, from a soft to a hard surface. So we do a lot of transfer training. Of course, it's much easier if they've got one extremity left. But if they're a double amputee, they've obviously got a lot more disability to have to deal with. And then energy conservation, work simplification. When they've had the amputation, they're having to expend a much higher degree of energy to perform tasks that you and I would perform with a fair amount of ease. So we try to incorporate into the activities that we're working with some techniques for energy conservation, for work simplification. That can be things like making sure that whatever task they're going to do, all the components are in one place, so they're not having to go from one place to another. And we all do this at home. I know I do. You know, one cleaning things here, and then you get distracted and you're over here, and we end up getting tired. Well, it's much harder for them because they are not as mobile initially to get around to do that. And then if they're lucky enough to go home, then we'll work out some sort of a home program for them. Again, that could be maybe some home modifications. Maybe we need to do something in their home to make it wheelchair accessible. Maybe we need to move the furniture around a little bit. Maybe we need to move some things from the higher shelves to the lower shelves. So that would be primarily what the home program would involve. So you can see with the amputations, there's an awful lot of work to be done. One of the other problems frequently seen with the diabetics is peripheral neuropathy, and that's often seen in the type 2 diabetes. And what can happen is some of the different things, the symptoms they're not always the same for everybody, but you can actually get damage to the cranial nerves, and that would be 3, 4, and 6. The ones that control the eye movement, and they can actually get paralysis of some of that movement. The most common problem that we'll sometimes see is diplopia, or that double vision. This is sort of a transient. It'll actually, wax and wane. They can actually work with this. But we sometimes will have to work with people who have that problem going on for a little while. So we'll have to teach them some compensatory strategies to actually work around that. Damage to the autonomic nerves can cause a lack of sweating. A lot of times what can happen if the damage is happening up in those larger nerves or the nerve roots, you can get damage to the radial and the ulnar and the median nerve. And what happens is the intrinsics of the hand, you can get sort of a flexion contracture. They get more of a claw hand. They can have a very limited grasp and release because of that weakness. So this would be a person that we would have to do perhaps a little bit of splinting with to make sure that they get into a functional position, and that can help to make their hand more functional for them. Again, this can sometimes be sort of a transient process. It may not be something that they have to live with all the time, but we do occasionally see people that will actually do some splinting with. Along with that, a lot of times there's some tingling and some numbness in their hands. And that was what the severe sensory dysfunction. It can be from one extreme to the other. Some is very, very mild, and then some is very severe. We try to teach them compensatory techniques for the visual problems, and we also teach them compensatory techniques for that sensory loss. You can imagine how difficult it is to try to do something even as easy as buttoning if you can't feel the button anymore. So they may have to compensate visually. If they're having both the problems, they don't even have the vision to go with. So you sometimes have to be very creative in what it is that you're trying to teach them to do. Obviously, the splinting we can use to help preserve that joint integrity. And then we also work a lot with safety awareness. If they're washing dishes, they need to know that perhaps to test the water, the temperature of the water, we teach them to use their elbow instead. If they've got the sensory loss in their hand, they use their elbow versus their hand, because that way they've got a little bit more of a temperature sense. All right. We see some of this overlaps a bit, but there are often sensory deficits that we see. Visually, there could be things like diabetic retinopathy, diabetic retinitis, or diabetic cataracts. They can have black spots moving in front of their eyes. They can have blurry vision. Some of the things that they describe, they can see flashes of light sometimes. That happens a lot with any of the retinal type of problems. So obviously that can interfere quite a bit with some of the activities that they're actually trying to do. So again, we're trying to teach them compensatory strategies to get around that. They suffer loss in the sense of touch. They can experience paresthesia. They may lose that vibratory or their positional sense where they know where they are in space. They can have a decreased sensitivity to pain in the extremities, but then conversely, they may have chronic pain in another part of their body. So they sometimes feel like they're a real mess. You know, there's either a pain or there's not a pain. And then that decreased temperature sensation that we talked about, again, either in their foot or their hand, that can be pretty devastating if they've accidentally got the water temperature too high and they suffer a burn. They're obviously, again, at a higher risk of developing a problem just because that healing process is so delayed with them. There can be some cognitive dysfunction. I don't see it as much, or at least I haven't in my experience with diabetics, but there can be some cognitive dysfunction. It's usually more of a memory problem caused by the high level of glucose. So again, they may suffer some difficulty doing their normal activities. They may find themselves more forgetful. They may forget where they've put things. They may perhaps if they're responsible for their own medication, they sometimes have difficulty doing that. So if they are having a cognitive problem, occasionally what we'll have to do is give them some sort of a memory aid to help them get through that, and give them little cues or reminders, either visual or verbal, whatever will work, to be able to perform their activities. And then also with the diabetes, you'll get the intra and the interpersonal problems. They go through an awful lot of emotions when they've got the diabetes, especially the ones that have actually had something as serious as an amputation, or they're really having problems with their foot and developing the foot ulcers where it's seriously curtailed maybe their social and their leisure activities. So they voice a fear of being on insulin if they're on insulin for the rest of their life. They are depressed. You know, you get that normal anger. You know, why me? Why am I the one that's having to deal with this? They have a lot of anxiety about their future because diabetes is something that, you know, it's not going to go away. They see or hear probably horror stories about, you know, some of the things. They know if they've had one amputation, they're more at risk. So this is something that they're going to live with for the rest of their life. So there's a lot of anxiety there. They can be real irritable. Can be easily discouraged, and that's not to say all of them are, but that can be a factor. And a lot of them will tend to restrict their social activities, and that could be either due to fatigue. It takes them more energy to be able to do things, so they just don't do the things that they used to be able to do, or they have to monitor them more closely because of diet restrictions and things like that. So those can all be things that We help them work through it. We may not work specifically with that. I'm sure that, that we have psychiatrists usually in all of the settings that we work with that help them to, or case managers that help them process through some of this and deal with a lot of these emotional things that are going on with them. But we're also aware of it when we're doing our therapies. As OTs, when we do our assessment, typically it will include the following, either all of or parts of the following. We test their muscle strength, and it'll be more specific for whatever problems they're tending to have, whether it's more specific in the upper extremities or the lower extremities. We test their fine motor skills, their manipulation, their dexterity to see if they're getting some problems with that, where they might have problems with their dressing or their hygiene skills. We test their grip and their pinch to see if they're getting that weakness in their intrinsic muscles. We test their balance, their postural control. We look at their sensory registration, their processing. Do they have temperature loss? Do they have that vibratory loss? We will double check to see if there's any problems developing in any of those areas. Visual perceptual skills, are they developing some problems with? Do they have the double vision? Do they have the blurry vision? Are they completely losing their vision? We test their self-concept, their daily living skills. Are there certain tasks that they can't perform or that they maybe need help with now that maybe a piece of adaptive equipment could help them? And we also look at their leisure interests because we want to get them as close to normal as we can. Going back to the emotional, I knew there was a story I wanted to tell you. We did have, so I can kind of give you an idea of how devastating that the diabetes can actually be on a person. At one of the psychiatric hospitals that I worked with, we had a young 21-year-old girl, and she was in college, very sociable. She modeled on the side. She was very popular, involved in a lot of extracurricular type activities. At the point that she came to us when she was 21, over a period of 6 months to 1 year, she completely lost her vision because of the diabetes. And that was such a dramatic difference for her. She just was totally unable to cope with it. She'd lost her friends. A lot of that was due to her. They were very sensitive to what she was going through, but she perceived them as pulling away from her. She stopped taking any interest in what she looked like. I mean, she couldn't see herself, so she didn't care. She figured she was ugly now. And she got so severely depressed that she was becoming suicidal, and she would not come out of her room. And her family couldn't understand, what was going on with her. They were obviously devastated as well that this young girl had lost her vision. So she was very difficult to work with, and what we tried to do with her was get her to pull her out of her room. We used makeup because we figured that was something that was very near and dear to her heart, were her looks. At least at one point that was very important to her. So what we did was we helped her by her sense of feel and working with different types of cosmetics, some that she was familiar with, some that she wasn't, to help her look better, or what she perceived. She felt that now she looked okay, so she started coming out of her room a little bit more, and it was a very long process. It wasn't an overnight type of a thing, but that's just an indication of how severe, some of the symptoms can impact somebody, especially when they're that young. Okay, some of the desired outcomes for OT when we're working with somebody that has diabetes. Obviously, we want them to have enough strength, enough physical endurance to be able to do all of their daily activities independently. So those are some of the things that we'll really focus on. We don't want them to be dependent on somebody else if at all possible. We want them to retain that normalcy that they had before. We try to teach them to incorporate energy conservation, that work simplification into their daily routine so they can accomplish some of these and more a lot more easily. We incorporate time management skills. their diet restrictions now. They have insulin, so they're more involved in more of a rest activity type cycle, just so they don't get into the fatigue factor that often happens with the diabetics. So again, we try to help them be more aware of that, to schedule their time a little more than they probably did before. We teach them compensatory strategies. We want them to be able to cope for any types of visual or sensory losses. We increase their knowledge of skincare and the skin inspection, because obviously as the circulation and the sensation gets worse, they need to be aware of what's going on if they are developing any problems. And we try to teach them coping skills to live within the restrictions of the disease without being handicapped, and that's very important. They really see themselves and perceive themselves initially as being handicapped, where it really doesn't have to be that way. And that one's sometimes the one that takes the longest. Just a little more on treatment. Obviously, being therapists, we always have to throw exercise in there. And some of the little facts about the exercise, it can actually help the body to turn off some of that excess glucose as energy. They're now using it up and reverting it into another form. The thing with the diabetics is it should be consistent. They should pretty much do the same amount every day, because again, you don't want to facilitate a fatigue with them, so they can't do some of the other activities that they should be able to do. We find that they may need less insulin as they actually start getting more mobile. So we have to make sure that nursing is very much a part of what we're doing. If we're increasing their activity level, they need to be monitoring as well to see if they need to make any dose adjustments if the person is on insulin. We try to help them to maintain what's called a good body balance. And if they are increasing their activity level, they need to accommodate by perhaps adjusting their between meal intake, just to sort of balance themselves off. And it sometimes takes a while to get that happy medium, you know, as they've increased the levels and their activity tolerance builds up and they're able to tolerate more activity. So again, along with the adjustments in the insulin, they need to learn to be aware of when they're starting to have problems, when they need to eat something, so they can balance that out. Usually abrupt, strenuous exercise should be avoided. So these are not the ones that we'll have doing heavy pump and iron and things like that. It needs to be more of a, walking is very good if there's somebody that doesn't have the amputations. Vigorous exercise actually has been shown when they have that problem with the retinas. You can actually, if you do too strenuous an exercise, there have actually been incidents of the retinal detachment. So again, that's something, if they are having that type of a problem, we have to be very aware of it, not have them doing a lot of bouncing around. The treatment with the sensory difficulties. Obviously, we want to increase their sensory awareness of their feet, and it may not be that they're getting the sensation back, but they certainly need to compensate for that by being more aware of where their feet are. And again, that encompasses maybe being more aware of where you are when you're walking, so you're not coming too close to things, not going barefoot through the grass or over rough surfaces without your shoes on. We give them the opportunity in the therapy rooms to practice some of those compensatory skills and teach them to use whatever remaining sensory systems that they have as backups. This would be the same as, say, you're working with a blind person. You teach them to use their hearing, their sense of touch, if they've still got some of that. So you need to be aware of what sensory systems they do have that are intact, to figure out what sensory systems can compensate. Again, we teach the skin inspection and that safety awareness, which would be the temperature, you know, using their elbow perhaps, moving the furniture. Cognitively, again, we give them the instructions on the concepts of energy conservation, the work simplification, safety requirements that they might need to use in case of the sensory loss, the time management skills. We instruct them on any types of secondary complications that might happen, and that would increase the tactile awareness problems that they might have, the circulation impairment, the visual problems. They need to be very much aware of the possibilities of that disorder as they go through, so they can anticipate that in their daily activities. And then we may have to actually use or incorporate the memory aids. I told you that cognitively you don't always see problems, but if they do show some of that memory impairment, we can use things like memory books or day planners a lot of times where you can cue them. They can also incorporate that time management where they're on much more of a schedule to remind themselves to do certain things. And as OTs, obviously, self-care is always there. Got to do those ADLs. If they have a need for adaptive equipment, say that perhaps their balance, as we're working with an amputee, they just don't seem to be able to get that dynamic balance to the point that they can actually bend over far enough to pick something up, we may incorporate the use of, say, a reacher to get some things from way above their head or way, on the floor. They may, if they're having sensory loss, need to incorporate some sort of a button hook to get buttons or a zipper pull if they've got the weakness in their hands. So we really assess, find out what their problem areas are. We may use elastic shoelaces, so they don't have to actually get down there and tie their shoes every day. They can actually slip their foot in. We encourage independence. Again, we don't want them to feel like they're handicapped, so we try to get them as independent as possible with all of their daily skills. And then what we do is explore the possible need for modifications perhaps in their home environment or even in the nursing home environment. We need to be aware of what their room looks like, if there's any shifts that we can make within the physical possibilities of the building to help them conserve their energy as they're in that home. And the one that's present but always the harder to deal with are those intra and interpersonal problems that they have. Again, we work a lot with the psychologists and the case managers and the social workers with them. We try to help them maintain their self-concept, and a lot of that is through helping them to be more independent with their daily skills. They feel much more self-confidence when they're able to do it and they don't have to rely on, say, nursing or some other caregiver to do that for them. We assist them in developing their coping skills. Again, working with the psychology department, maybe figuring out what techniques they have to employ. Is it visualization? Is it breathing? Whatever they need to use to help them to maintain their coping skills. We provide them instruction in practice and relaxation techniques to reduce stress, because the stress with the diabetes can actually inhibit insulin production, and it releases hormones that make the glucose and the fatty acids. When you get into that fight or flight, that glucose comes out so your muscles can start working. So it can actually be very counterproductive in the case of the diabetes. So we do try to help them deal a lot with their stress. And then we assist the family, work with family a lot, pull them into therapy sometimes to let them see where that person is, what they can do by themselves, so they're not always jumping in and doing it for them and feeling like they have to do everything. When they can see that the person can adjust and live a fairly normal life, then they feel much better and don't feel like they need to be there all the time. They allow them to be more participatory in that family unit again. And that's it. Any questions? Yes.
Looking at the quality of life, I think the ability to be able to smile, aesthetics, the ability to be able to chew and enjoy a meal, and the ability to be able to speak comfortably.
Right.
I think all of those affect the self-esteem, your mood, and the way your overall quality of life. In dental practice, we because of decreased manual dexterity, poor circulation, and a lot of diabetics are very predisposed to gum disease.
Right.
Now, specifically, how much you did say that you work with nutritionists and people in. Specifically, how much communication do you have with the dentist, and what kind of modifications do you do for your patients?
Well, obviously, with the grooming and the hygiene, we often find, especially in the elderly population, a lot of times when they come from home, that their oral care is not very good, and if they've got the diabetes as a compounding factor in their oral care can be very bad. If we see a problem, you know, that we can't deal with, if it looks like they do. What we'll usually do is refer to nursing and ask for maybe a dental consult to see if maybe we can get, I don't know that there's something that we would do specifically, but we can certainly incorporate any recommendations from, say, a dentist that they would recommend that we could incorporate into our daily activities for them. So we usually will alert nursing first if we notice a problem as they're doing their oral hygiene. Absolutely, absolutely.
So that they can be in.
Yeah, it could be that simple. If they can't grasp it and they just don't do it at all because they can't hold the toothbrush. Yeah, you're right. Or sometimes, again, if the visual problems are a factor, you know, if they can't see themselves and they don't realize how bad it's actually getting, they have a tendency to sort of maybe play that down, or they've got so many other things going on that really takes the back burner for them. And we help them to realize that that's still a part of their routine. It needs to be. So, yeah, we just really try to make their life a lot more normal, get it back into that pattern. Anything else? Thank you.